You. So I think this is the first time in my long career you just heard about that I have ever quoted Stephen Covey, who had a kind of storied career and wrote the book, The Seven Habits of Highly Effective People. He said something, though, about trust that I think is so relevant to our conversation today. He said, trust is the glue of life, the glue of life. It is the most essential ingredient in effective communication. It is the foundational principle that holds all relationships. I think that is all the more true in these days, in these disruptive times in which we're living, when the nation is polarized, when truth is called fake news, when if you have a Twitter account, you have a megaphone, and traditional relationships like healthcare system, patients, doctors, are indeed fraying. The healthcare system is not immune. A recent Gallup poll showed that 2 out of 3 Americans do not trust the healthcare system, and that is devastating. So we are going to discuss how in the world we got here and what can be done so that the glue, once again, adheres. My guests are Dave Chokshi, who is a practicing physician at Bellevue in New York City. He is also the population health officer at New York City Health and Hospitals. Tony Villarreal is the dean of the School of Nursing at the University of Pennsylvania. Tony is also a member of the Board of Trustees of the American Board of Internal Medicine Foundation. And Rich Barron is the CEO and president of the ABIM Foundation, as well as the ABIM itself. He practiced medicine for 30 years. In the interest of transparency, I want you to know that I also am a member of the Board of Trustees of the ABIM Foundation, and collectively, the 4 of us have been involved in launching a trust initiative through the foundation that you're going to hear about as we go on. So Rich, let me turn to you first and ask this 10,000-foot question. How in the world did the healthcare system become a source of such distrust and mistrust?
Well, that is a terrific question, Jackie, and one that we've had to think a lot about both at the board and at the foundation. It won't be news to many of the physicians in the audience that the whole issue of board certification all of a sudden became really hot. And lots of people seem to think this was a terrible idea and somehow illegitimate. And it was shocking because what the boards did was gather groups of experts who then created expectations of standards of what it looked like to be a good doctor. And under this onslaught, we stood up and said, hey, wait, this is what we do. We have facts, we have expertise, we're creating standards that are evidence-based. And it made 0 difference in the conversation in the community, none. And we discovered that we had let our relationships deteriorate with the physicians who engaged in the process. And in the context of a set of really deteriorated relationships, people came to believe lots of things about the boards that turned out not to be true. As we started to think about that, we realized, hey, wait, healthcare, all of healthcare, is relying on science and expertise in the service of patients. And when patients seek out clinicians at any phase of the healthcare system, what they're hoping for is having that expertise applied to their benefit. But we're now in an environment where trust is deeply being corroded, especially trust and expertise. We see it in politics. We see facts attacked. We see, you've already mentioned, alternative facts and fake news. Many of us in healthcare thought, oh, thank goodness that's politics, that's not healthcare. We're in our hospitals, we're in our practices. We've still got New England Journal articles to back us up. Of course the patients will trust us. And guess what? That's not what's happening. So the foundation's been thinking about a trust initiative in healthcare and looking around at various kinds of practices, intentional practices, that healthcare institutions are doing with the explicit goal of building trust. And we're discovering things like people putting comic books in the waiting room to explain at the University of Chicago how you can get yourself into the conversation with the computer so that when the doctor's looking at the computer, there's a graphic guide. Those kinds of things where people are thinking about how do we empower patients to create relationships so that they can benefit from that science, we think that's going to be a critical issue in healthcare.
But what you're saying is that you are struggling in part because things became too hierarchical. You think if you set it on high, it would trickle down in an effective way.
Exactly
That didn't
right.
happen.
That didn't happen, and I think one of the themes that I'm hearing at lots of sessions in the Aspen Ideas is the idea of community engagement, of connection, that relationships matter, that science, in fact, standing by themselves are not going to be effective. They're not going to drive change. They're not going to engage people, and most importantly, they're not going to engender trust.
Dave, you are, as I said earlier, a practicing physician. You practice at Bellevue. Your patient profile is low income, Medicaid or uninsured, sometimes immigrants. Take us into a clinical exam room and tell me what happens when you sense the person across from you isn't trusting you, what you're saying, and what you're advising them to do.
Well, my starting point is that trust is the lifeblood of healing, and particularly any healing that takes time. And it's something that, in fact, is antecedent to an encounter between a clinician and a patient. The decision, particularly for the patients whom we serve in our system, the decision to seek care is one that requires trust. And so if the starting point is one where there's a trust deficit or a trust gap, we may not even see patients in our exam rooms in the first place. And this is something that I think about a lot, and more so in the last couple of years as some of the rhetoric at the federal level, particularly around immigration policy in this country, has led to people being fearful of seeking care, people being fearful of taking advantage of benefits like Medicaid, which are vital for their health and for the health of their children. So these are, sort of the external factors, as well as how it imbues any given interaction within the exam room itself. And just the other thing that I would say to kind of convey how trust plays out in any given encounter between a patient and a clinician has to do with the fact that it requires time. And this is something that is in short supply and is getting even more scarce as there are more and more requirements put on clinicians, as Dr. Barron alluded to, as the electronic health record takes up more of a doctor's attention. So how is it that we can actually create the time and the space to engender those healing relationships that are required to help someone stay healthy?
When you have patients who you feel don't trust the system, even possibly you, what is the impact on their health? You said some of them just don't show up, but when they do show up, non-compliance with follow-up or?
Certainly, you can see it in terms of people not taking their medications, vital medications in some cases. One thing that I think about a lot is that in many cases, again, particularly for the patients whom we serve, the people who are least likely to trust the system or to trust clinicians are those who are most in need of medical help. And so this ends up manifesting in ways that are counterproductive, both from the system's perspective, but more importantly, from the patient's perspective, meaning they will wait until it's a crisis situation with their health. I think of a patient whom I took care of who presented with very advanced heart failure for long-standing high blood pressure. High blood pressure is a treatable condition, something that is straightforward, very common in our country. But it was a patient who was a Spanish-speaking immigrant who chose not to seek care until her pathology was so advanced that she presented not being able to breathe with chest pain in the emergency room. So these are some of the ways that that what feels like something that is conceptual becomes very tangible and real for patients.
Tony, nurses are in the somewhat enviable position of being a more trusted source in the healthcare system than certainly doctors. Why?
So we've had that reputation in the same Gallup polls for many years. And in thinking about why, I think there's several things that come to mind. I think one of the things that you said was time. It's not just time in the waiting room, but if you're thinking about an inpatient unit, the time that we have with the patient over their course of stay and then when they come back. But it's also what happens within that encounter. Trust is basic to any type of relationship, and we have the time to develop, but it's also the proximity that we have with the patients over that period of time. And it's not only the proximity that we have in terms of what they're dealing with, but understanding the context of their health and their well-being and what's important to them. We have the time and we have the trust to be able to get that out. But we also have what we say as distance within that relationship, giving people the time to say, as they have an encounter with the physician, and then it's the nurses that come back and said, well, what is that, and is that okay, and what are you thinking? So we provide that safety and distance that allows them to sort of think about what was said, think about what it means in their life, and then move forward. In addition to the relationship component of nurses, we also have leadership components in the system. And so when you think of the designation, for example, of magnet hospitals, which really is an indication of the level of autonomy of nurses in the system, magnet status has been associated with better health outcomes. So again, the leadership that nurses have in the system to be able to direct care, to be able to practice to the scope of their license has great benefits, not only in terms of how nurses practice, but also how physicians practice has outcomes in terms of patient satisfaction, as well as other things such as length of stay.
I've also heard you say that patients do not see nurses as the decision makers in the way that they do nurses, and so they are a little bit out of the line of fire. But here's my question. As nurses become more autonomous, as they pick up more responsibility, nurse practitioners can go out on their own now in some states. Is there a risk that nurses become as distrusted as doctors?
So I don't think it's that nurses aren't decision makers and people don't see nurses as decision makers. They certainly see nurses as being able to make things happen, as being able to move a physician, to move a system, to get them what they need. What's different, I think, about the relationship with nurses and the health system, and again, I'd love my physician colleagues to comment, is that nurses don't have the financial conflicts that physicians have, or the financial conflicts that they have to consider in terms of decisions, in terms of, how many, if we're looking at a fee-for-service basis. We've had some really bad actors physicians who have had, who order tests, but also have a property or have ownership in a company related to diagnostics. So you hear about the pharmaceuticals and the kickbacks that they have there. Nurses don't have that type of relationship. It's more of a system-based. I mean, we're up with the bed charge, or in a federally qualified health center, we're billed differently. So we don't have those same type of financial conflicts that are as evident as physicians. So I wonder also if that's part of the reason for the mistrust. It's not that we can't make decisions. I think people see us as making things happen, but we're not as conflicted. And I think even as we're more autonomous in our practice, that those relationships aren't going to be as dramatic as they are with our physician colleagues.
You're nodding your head vigorously.
Yeah. I really agree. I think it's a great point. And going back to Rich's comments at the beginning, I think of the changes in trust over time. You can kind of divide it into, there are secular trends related to distrust in institutions, distrust in science, and then there are things that are particular to to the medical system. And I think this is an example of one of those where there's been a growing commercialization, what some people call the medical industrial complex. Part of it is also the backlash from managed care reforms in the 90s, where many patients felt as though the effort to control costs was really about reducing their choice, and it came on their backs. So I think these are things that have eroded trust, particularly in physicians, over that period of time.
The foundation years ago was in the lead on this question of conflict of interest.
Conflict of interest, and also thinking in the Choosing Wisely program about effective use of resources. But I think I think people go to the finances when the trust is already lost and is already at threat. I think in some ways the biggest difference that I might see between the physicians have plenty of opportunities to build trust. It's that we may be wasting those opportunities trying to solve a diagnostic problem or trying to solve a therapeutic problem. We think our job when we're seeing the patient is to figure out what's going on and what to do about it. And in some ways, the whole act of doing that involves a sort of subtraction of the patient. It's almost like the patient gets in the way of trying to figure out what's really going on. And then doctors blow it because what we're trying to do is figure out what's going on and lose the ability to connect and then make the knowledge powerful and effective for people.
Why do you think doctors see patients as getting in the way? We've heard so much in the Ideas Festival just in this first day about patients being so much a part of the process now.
Absolutely, they should be, and I think in our evolving vision, they certainly are. But when we train doctors to do diagnosis, we're training them to look through lots of things to see something else. It's not exactly the patient getting in the way, but it's almost like the doctors are looking past the patients or through the patients to find something else. And I think the nurses have the privilege of being able to focus on that patient and that experience. And I think that's one of the challenges that we just don't manage well in terms of our knowledge won't work if we're not better at seeing our patients, connecting with our patients, and creating those relationships.
And I think that again, the differences between what a physician does and a nurse does are complementary. And so the whole notion of being able to work together as a team with the patient as central is something that I think we're trying to do better, certainly on the education front and certainly at the practice front. So we need good diagnostics. We need physicians to be able to figure that out. And then we need nurses to both help patients figure that out and what that means in terms of the choices that they have, as well as helping them select the best options for their care based on what that is.
At a nursing innovation panel that you were on earlier today, someone else on the panel spoke about the kind of training that nurses get in school, related to that human touch, the human relationship. Do doctors get that?
I don't think we do. I think we
even now.
I don't think we do, and I think that this is one of the reasons why I think we're so at risk is because if we think we're going to address the problems by looking at the objective lab results and the x-rays and the tests and then consult the literature and then say to the patient, well, here's what's going on and here's what you need to do, and if along the whole journey we never focused on connection, on relationship building, on development, on understanding the patient's individual predicament and making sense of that, we're not going to be able to use those skills effectively, and patients won't benefit from them. And I think nurses do it much better in terms of understanding in training how to connect with people.
So let me just share it. I was talking to some of my undergrad students, and they were telling me that they were taking an interdisciplinary class with med students that was called Humanism in Medicine. They were undergrads, they were working with medical students, so there's both age and education difference. And I said, how did that go for you? And they said, well, we were really intimidated at first, but then as we started going, and it's like, we've already had that. We already know, we already know that. And so when they said, when we had to give our whole philosophy of care, the whole class voted on their, quote, philosophy of care as one that they wanted to emulate. For the nurses, it was really good for them to see, this is what we have, this is what we bring to the table, and we are a value in that system. So again, more interdisciplinary work, and again, cross-training would be really useful.
As part of the Foundation's initiative, there have been a number of essays written in and published in JAMA. And we've been looking at various relationships inside the healthcare system, not only patient, doctor, nurse, patient, et cetera. And one is the relationship between doctors and these ever-expanding large healthcare systems. Dave, that was your slice of the pie. And in your essay, you talked about the need for a compact. So tell us more about that.
Yeah, and just to tie it, it's a great question that ties, I think, to the conversation that Rich and Tony were just having, in the sense of, we should challenge this premise of how our healthcare system is organized today. If we agree that trust is a central component to a high-functioning, high-performing health system, then shouldn't we actually turn it on its head and say, let's organize it around the natural places where trust does exist, whether it's because of the way that nurses are trained or around the more continuous relationships that primary care doctors have compared to surgeons or specialists. Or even, non-nurses, non-physicians. You think about community health workers, and a critical part of, the fact that they are effective in changing the trajectory of illness for many patients, because the relationship is central. It's not scientific expertise. It's something that is born from trust, rather than trying to fit trust around, the other components that we're talking about. And so, one dimension that we explored is around how that manifests between clinicians and organizations. And there's almost been this parallel trend, again, which I attribute in large part to the commercialization in medicine, where frontline clinicians, people who are seeing and taking care of patients every day, have grown distrustful of administrators and executives, the people who are running healthcare systems or health plans. And we see that bleed over into distrust between patients and clinicians as well. So one way we think to take a concrete step forward is to name that and say what we really need is a compact whereby administrators and clinicians come together and say, these are the rules of engagement to make sure that the input of people who are closest to the points of care are actually helping influence how the system is organized.
Should we think about that between the medical team and the patient, having a similar compact?
Oh, absolutely. I think that the ability for the medical team to connect in the way that nurses are able to do individually, to connect collectively and say, we're here to address your need, to meet your need, we're here in service to you. If everybody goes to work thinking that's what they're doing, I think we get a much higher performing healthcare system. And when people think, I'm going to work to read the best x-ray I can, or I'm going to work to figure out the right dose, that if that's what we think we're doing when we're going to work, we're going to miss the mark. And the more we can collectively as a team understand ourselves as in service to our patients, the more successful we'll be.
When you think about solutions, Tony, what's on your mind?
I think the idea of the interdisciplinary care team is important. It's not, again, just the individual relationship with the patient is important, but we function within teams, we function within systems. And I think to the extent that we can use that and approach that, I think we're better off. Just as an example, as you were talking about the care team, my colleagues at the Hospital of the University of Pennsylvania, to address issues around quality, have a team in each unit that's comprised of a physician a nurse, and also a quality person. So again, they look systemically at what are the problems, what the root of the issue is, and they work on that collectively. So again, to see that sort of interdisciplinary collaboration of saying, this is not a medical problem, this is not a nursing problem, but this is a problem that's affecting patients, and we need to work together on that, is again an example of what we need to do.
Yesterday, the Wellcome Trust came out with a significant survey. You've probably heard a lot about it here, related to trust in scientists, I think was the word that they used, not healthcare specifically, if I recall. Or am I wrong? And again, at the 10,000-foot level, the picture looked a little better than this Gallup poll showing 2 of 3 Americans distrusting. So what do you make of it, Rich?
Well, first of all, I don't think we can say that trust in healthcare is high, and I just think that's our day-to-day experience. And I too spend a half a day every couple of weeks in patient care, and I think there's a lot of suspicion there, and a lot of, are you doing this for you or are you doing this for me? That's one of the financial questions. And are you doing it safely? Is another question that's out there. So I think there are a lot of things that have eroded trust. I think I very much agree with Dave's point earlier, and Wellcome found this too, that in countries with income inequality, the level of trust was a lot lower because in a sense of income inequality, I can't trust that my voice is being heard, that my need is being considered. And I think it has ramifications that at all levels of governance now at the American Board of Internal Medicine, we have patients and we have members of the healthcare team at every level of governance. Completely changes the conversation at the governance level. And I think institutions that do better at that, at hearing those voices, will do better ultimately at building trust.
Tony, did you?
I think it's also how we communicate about science. I mean, we were part of a discussion before coming here about antimicrobial resistance, and findings change over time. So if cheese and eggs were good for you one year, they're not good for you next year, and it's like, well, why believe that? Because sooner or later, nobody knows what's going on. I'm just gonna do what I need to do. So again, helping the public understand that it was true at the time, that was the best evidence that we had, but now we know more. And helping people understand that that's what we go through as well. But I don't think we do a good job of saying, this was the best evidence that I had at this particular time to be able to move forward. And now we have a different story that informs us a bit better. So I think those conversations are important.
There's an interesting angle to this also, which is, I think about the question as how can we be more worthy of patients' trust and, the people that we're trying to serve? How can we be more worthy of their trust? And, the eggs example is a great one. One that I encounter in my clinical practice all the time is how screening recommendations have changed. And so I'll get a 43-year-old woman who comes in and requests a mammogram, and it prompts this conversation about how, the recommendation now changes for routine breast cancer screening starting at age 50 rather than age 40. Well, why did it change, and isn't more screening better? Why are you withholding, this service that could help me detect cancer at an earlier point? And so, yes, I do think that we have to have more deliberate conversations about evidence. I think we also have to hold ourselves to a higher standard when it comes to, to promulgating recommendations based on evidence. There's a great book co-authored by Vinay Prasad and Adam Sifu called Ending Medical Reversal, which really, sort of cuts to the heart of this and says that, well, are we actually making decisions and recommendations not using a sufficiently high evidentiary threshold? And is that part of the reason that there has been this erosion of trust? So I think it's something where we have to turn the spotlight inward, to our profession and figure out if there are ways that we should be organizing it differently to be more worthy of people's trust.
And one of the dangers of people beginning to lose trust in studies that may change over the course of time is that in the world in which we're living, there are always other messengers out there willing to step into the void, regardless of the value and accuracy of the information. that they bring to it. What's the danger of that, Rich?
Well, this has, in the world of the internet and social media, whether the information comes from the New England Journal or your crazy Uncle Joe, if it's on your Facebook feed, it all looks the same.
Yep.
And increasingly information is not sourced and people don't know where it came from. And if it comes from someone whom you otherwise have a relationship with, you may believe that beyond what you would get in more authoritative ways. The American Society of Clinical Oncology did a survey last year. 40% of people in this country believe you can cure cancer with natural therapy alone. 40%. And it would be great if it were true. It'd be lovely to avoid toxic chemotherapy. And people who are in a situation where they don't trust healthcare may find their ways to a variety of other providers now in a much more heterogeneous marketplace.
I'd like to open it up to all of you. There are two folks with mics. Wait for them to come over to you and then speak up. Let us know what your question is. Yeah.
Hi, I'm Julianne Tomlin from Center for Care Innovations in Oakland, California. And I think one of the things I expected to hear a little more of, and I'd love to hear a little bit more, is how we're increasing trust with those populations where there wasn't as much trust to begin with. And I'm speaking, of course, of those who've been exploited in research and who have not had access to the level of care that those with more privilege have. So I'd love to hear about a little bit more about that.
I'm
Well,
going to
I
defer
think
to Dave.
Yeah.
Sure.
Yeah.
I'm glad you're asking the question. I think it's a very important topic, and frankly, I don't think there are many easy answers to be had. I think, yes, some of it has to do with more structural solutions, that get at the bigger picture of how populations and people that have been marginalized historically are recognized, and that history, is recognized in a way that organizes research differently in our country, that organizes clinical care in a way that changes the starting point, for interfacing with people who come from marginalized communities. And I think, to that point, and again, this is very much born from my clinical experience, I really believe in the importance of small solutions, to do that. So just to give you a very concrete example, this is something that I adopted from my wife, who is a teacher, who made it a practice that she was going to call the parents of her students when there was some good news to be delivered, and not just when there was a problem in the classroom. And so I overheard her doing this one weekend, and I said, this makes a lot of sense, in terms of forging the relationship with, in her case, parents. So I started calling my patients when I had normal results to convey, and not just when I had, something that was abnormal. And it's those, small things, and then architecting a way to support that type of relationship building. Our reimbursement system is not built for those types of things. I don't get any payment, for calling a patient to convey a normal test result. But it's the accretion of those small human interactions that engender greater trust.
And if I could add one thing also from my own clinical experience, I think a personal awareness of structural racism on the part of clinicians. And what do I mean by that? All the things that happened to that patient before they got into the exam room. Because I vividly remember in community practice doing early in my career very comprehensive history and physical on an African-American 50-year-old sign painter. And he looked at me afterward and he said, "Doctor, did you do the same exam on me you would have done if I had been a US senator?" And it was a really incredible moment for me because of course I did, I thought. Why would you even ask? But of course he asked, because he had a whole bunch of history and experience that I knew nothing about. So I think the more healthcare providers can understand that lots has happened to people before you see them, and if you start the story when they come in the exam room, you're going to miss all that.
I just want to talk about systems of care like you were talking about. Big fan of federally qualified health centers that are in the community. Many workers come from the community, whether they're physicians, nurses, but community health workers as well, that attest to a whole set of needs, not just the medical care, but again, the social needs as well. So again, the big fans. We have one in Philadelphia that deals primarily with homeless. What drives them into the FQHC is that there's showers and laundry. Oh, and by the way, here's the mental health care provider, and here's, X, Y, and Z. Another program, the PACE program, which deals with Medicare, Medicaid, fragile elderly folk. And again, it's a capitated program, Medicare, Medicaid eligible, but again, you take an array of their whole set of needs there in order to reduce hospitalization. But again, it means that making sure that they don't have bed bugs in their home, that they have transportation, that they're getting their meds on time. So again, systems of care that can support taking care of the whole person and their context, I think is where we need to go.
Hi, I'm Sam Espinoza, right here.
Where? Oh, there you are. Okay.
I know I'm short and I want to stand up. Thank you for the question that was just asked. And building off of that a little bit, I work in research and policy advocacy, and one of the things that came up a lot for us, and I was hoping you guys would all talk about or touch on, was that trust is a two-way street. And so in this past session in Colorado, we worked on getting the Maternal Mortality Review Committee codified in statute. And in doing that, we talked to a lot of different moms who had experienced morbidity, or one mother who lost her daughter when her daughter was going into childbirth. And the thing that was like the common thread between all of the stories we heard was I was trying to tell them that something was wrong and they weren't listening to me. So I was saying that I was bleeding too much and they're like, no, you're just pregnant. And so I just want to hear you guys talk a little bit about trust being a two-way street.
Tony, why don't you take that on? Because I know you wanted to talk about what can the patient do to improve the relationship?
Right. So again, it's, we talk a lot about an educated consumer, or again, making sure that they have participation, but it's us helping them figure out how to navigate the system. So again, how to make their voice heard. And again, if you're not getting it heard in the way that you need to, then what are other things that you need to be able to do? You need to find somebody that's going to listen to you. And again, that doesn't happen. That happens across the board, as I know my husband would like to tell you about his experiences with the healthcare system as well. But again, it's again speaking in a way, helping the clinicians understand what's going on and finding somebody who can advocate within that system for you.
But I think
it's not easy. It's not easy.
I think you're also asking about ways clinicians should behave differently, and clinicians can't expect patients to trust them if the clinicians don't trust their patients.
Oh,
And I think that's pretty foundational.
And I would just add on that point, it's simple things. It's listening. I like the notion of a two-way street. One way that I think about it is it's really about respect, and if the beginning of a relationship is not one that starts with respect, I don't know, it feels like the concept of microaggressions. I don't know if there's an analog, like micro dissing, all of the disrespect that accumulates, over time, and particularly again for people who are low income, people who come, from certain races or ethnicities, who are not starting at a neutral level when it comes to their expectation of respect in a system. And so I think the onus on that is really on the clinician side rather than on the patient side.
I want to introduce a level of skepticism about some of what we've talked about up here. It feels to me that sometimes healthcare professionals and systems go through phases of things that sound really good. Consumer-driven healthcare, patient-centered care, and now we're here talking about community engagement and paying attention to the whole patient, including issues of homelessness and the need for a good warm shower, et cetera. How do you translate this into something that becomes real?
I don't think these are new approaches. I think we've been trying to deal with that, perhaps using new terminology over a period of time, and hoping that it sticks. I could say that, you know, in patient-centered care, that movement started in pediatrics long time ago. It's now taking over in some of the adult population. So again, if we're talking about, quote, innovations that just haven't scaled up and uptaken, that's one. And I would say it has to do with the financing system, because what I hear, and I'm sorry to say from my physician colleagues, that if we don't get paid for it, we're not going to do it. You know, if we don't get reimbursed. And again, that could be a real financial model, but then we need to develop models that will support the kind of care and activism that we want to be able to do.
Another question?
So I'm from a federally qualified health center in Los Angeles, and I wanted to talk about the financial issue, is that we are still being paid by the visit. And we have care coordinators and community health workers, but we're not paid for them. When I share patient experience data with a provider, the patients are saying, my provider didn't spend enough time with me. And our providers feel like they can't sit down because they have to get through to the next patient. So if we don't change the financial system, we're not going to be able to build the trust. I think it takes education, but it also takes a different financial system to allow our providers to do it.
Yeah, I wholeheartedly agree. I'll just make the brief point that, you know, again, if we tie trust to continuity, and continuity, you know, rests in our healthcare system in primary care. And so changing the financial system, a big part of that is ensuring that we have sufficient investment in primary care. And there is, you know, a burgeoning movement, and Rich really has led this over his career, to ensure that there is a right sizing of investment in primary care, so that that time and that continuity that's required to get at what you're talking about is lifted up.
Yes.
Hi, Shilpan Patel. I'm chairing the American Medical Association's LGBTQ Advisory Committee. And so I feel like it's really great that we talk about building out culturally competent care and making sure we teach that in medical schools and across professional schools, et cetera. But how much of this is also on building a more diverse healthcare workforce?
Absolutely.
Because I feel like that's something that, you know, people often trust people that have the same background or same color of skin or gender or whatnot.
One of the winners of the Trust Practice Challenge that the foundation did was an LGBTQ clinic in Iowa, where the group of people got together, some from that community, but basically said, let's look at all the ways we could meet the needs of this population better, beginning with how do you even record preferred pronoun in classic medical records. So if you're going to take on those issues, yes, it's key. And I think that population is exemplary of other populations that feel, wait, this healthcare system isn't about me.
I would like to take the moderator's prerogative and ask the final question to Rich, and that is, you started by talking about the strategic initiative the foundation has undertaken to try to rebuild trust. What does success look like? What would you hope success would look like?
Well, I think Dave said it beautifully in saying we need to think about how to be trustworthy. We need to understand as a healthcare delivery system that being trustworthy is not something we should take for granted. And we shouldn't just assume because we go to work and we're trying to do the right thing that we will be trustworthy. And we should institutionally take seriously what are things we can do, behaviors we can build in, whether it's recording preferred pronoun or being aware of structural racism or training teams or doing team-based care so that handoffs feel more seamless, so that people feel known and recognized. These are things that can be created by institutional focus. But if institutions are focusing on RVUs or they're focusing on the latest technology or they're focusing on throughput, they're not going to focus on how do we become a trustworthy institution.
For those of you interested in learning more about our trust initiative, Daniel Wolfson is sitting in the front row here. He is the COO of the foundation and is Rich's partner in this, and he'd be happy to share a lot of ideas that he has. So I want to thank you all for joining us. Thank you for a great conversation.